Let's start with our next session, please. Light band करें. Let's start with our next session. We have a physician, endocrinologist amongst our surgeons group. Dr. Dalwadi is here, and he's discussing a very common syndrome, dumping syndrome, what we commonly have after gastric bypass. The patients usually are very worried, are very unhappy with this sort of feeling. So let's know what is dumping and how to manage, what are the symptoms of dumping syndrome post gastric bypass. I invite Dr. Pradip Dalwadi, a renowned endocrinologist from Surat. He'll be speaking on the topic.
Very good morning, everybody. I think now it is time to say good afternoon. First of all, I'm really thankful to Dr. Vikram Lotwala and Bariatric Society of Gujarat for giving me the opportunity to talk in front of you. And today, the topic which is given to me is dumping syndrome after Roux-en-Y gastric bypass. I know you might be knowing each and everything about dumping syndrome, and you might have seen more dumping syndrome than what I have seen. So this presentation might be just a revision for you. So if I tell you today what I am going to discuss is about dumping syndrome in brief. I'll be discussing the prevalence of dumping syndrome. Then I'll be discussing sign and symptom of dumping syndrome. Subsequently, I'll be discussing what are the pathophysiological aspects of dumping syndrome and what are the newer theories behind dumping syndrome. Then we'll be discussing how to diagnose and manage dumping syndrome. So let me start with dumping syndrome. Dumping syndrome is a frequent but under-recognized, under-diagnosed entity at the end result of complication of esophageal, gastric, and nowadays bariatric surgery. Nowadays, incidence of bariatric surgery is increasing dramatically in last decade, and we see some sort of complication at the end result of bariatric surgery. And dumping syndrome is one of them. Dumping syndrome was first described, it was a group of symptoms which was first described by Hertz et al. In 1913. Subsequently, a terminology, dumping, which was coined by Max et al. In 1922, based on the observation of rapid gastric emptying on contrast radiographic examination. So it was first time a dumping syndrome, a terminology which was coined by Max et al. But this group of the symptom was characteristically reported by Hertz et al. In 1913. If you ask me the prevalence of this condition, it varies because of heterogeneities of various studies. But the prevalence depends on type and extent of surgery and definition of dumping syndrome used by various investigators. Recently, one of the review which was published in Journal of Obesity in 2017, it says that dumping syndrome is quite common. It depends on the type of the surgery, and the prevalence of dumping syndrome is 20% if vagotomy with pyloroplasty is done. It may be up to 50% if the patient is undergoing esophagectomy, and it may be up to 40% if the person is undergoing Roux-en-Y gastric bypass with sleeve gastrectomy. Some of the other articles do says that dumping syndrome is quite common. It may be up to 70% in certain type of situations. So prevalence varies with the studies, but it may be up to 40 to 50%. One of the largest study which was carried out by Ramadan et al. In France among the patients who are undergoing bariatric surgery. In this study says that dumping syndrome was seen in 3% of the patients undergoing laparoscopic gastric bypass, or seen in 43% of the patients undergoing Roux-en-Y gastric bypass with 30 mm linear stapler at the end of 6 months. So the prevalence of dumping syndrome is quite high even in the Western populations. So it is also quite high. We can say that it is common even in our Indian scenario. If you ask me the symptoms of dumping syndrome is not a single entity. It consists of constellation of symptoms that can be categorized into early dumping syndrome as well as late dumping syndrome. Early dumping syndrome is more frequent than late dumping syndrome. It may be occur in isolation, or it can be seen with late dumping syndrome. Around 20% of the patient, 25% of the patient can have isolated late dumping syndrome. So now what is early dumping syndrome and what is late dumping syndrome? We all know patient with early dumping syndrome will have a manifestation of symptom just after eating, just 30 to 60 minutes after eating, they will have some manifestation of the symptoms. And this symptom is dumping of hyperosmolar content into the jejunum, which cause osmotic shift of fluid from the intravascular compartment into the intestine and subsequently leading to distension of intestine, which is responsible for GI symptoms like abdominal pain, diarrhea, borborygmy, bloating and nausea. Because of depletion of intravascular volume, it can lead to vasomotor symptoms like flushing, palpitation, perspiration, tachycardia, hypotension, and rarely even syncope can occur in patients with early dumping syndrome. If you ask me regarding a late dumping syndrome, it usually seen 60 to 180 minutes after eating. And usually these symptoms are exactly like that of the hypoglycemia, because patients are actually having hypoglycemia. And this hypoglycemia symptom may be cholinergic, called neuroglycopenic symptoms. These are fatigue, feeling of fatigue, weakness, confusion, hunger and syncope. It may be adrenergic symptom because of high adrenergic output like perspiration, palpitation, tremor and irritability. So, patient can have early dumping syndrome, more frequent than late dumping syndrome. Both the entity can coexist in one patient, that is quite possible. If you ask me regarding the pathophysiology, apart from dumping of hyperosmolar content into the jejunum, recent literature do says that it is not just osmotic shift of fluid between the intravascular compartment to the intestine. It may be because of release of certain vasoactive peptides into the circulation, which may be responsible for vasomotor symptom. Like one of the peptide which is released into the circulation is neurotensin, which is potent vasodilator and can lead to hypotension. So this vasomotor symptom is not just because of loading of hyperosmolar content into the jejunum. It can be because of number of hormones which are increased into the circulation in patient undergoing Roux-en-Y gastric bypass surgery. Late dumping syndrome, we all know, late dumping syndrome is rapid absorption of glucose. And let me tell you, glucose is the most important stimulus for insulin release. So when there is a rapid absorption of glucose, it stimulates insulin release. Apart from that, we all know there is increased incretin release like GLP-1, and it is also a potent stimulus for insulin release. So because of rapid absorption of glucose and increased incretin release, patient can have exaggerated insulin release. And because of that, patient have initially hyperglycemia followed by severe hypoglycemia, and because of hypoglycemia, at the end of 2 or 3 hours, patient can have autonomic symptom or neuroglycopenic symptom which I have described. So this is the pathophysiology behind the symptom of dumping syndrome. Now if you ask me how to diagnose dumping syndrome, careful opt-in medical history and thorough symptom evaluation is extremely important, because sometimes this kind of symptom may correlate with other pathology, like sometimes patient may have stenosis and can have vomiting and nausea. So it is very important to have a detailed clinical history. One of the most important clinical clue which patient can give to you is that when the patient comes to you and patient tells that, sir, I am having profound fatigue after taking meal and I need to lie down for a while, that means patient is having dumping syndrome. So if the patient comes to you with such a single symptom, based on that symptom you can diagnose that this patient might be suffering from dumping syndrome. Many symptom-based questionnaires are now available for a clinical use as well as for epidemiological use, like 6-star questionnaires and art dumping questionnaires. So many questionnaires are now being used to diagnose these conditions, and it was previously being used. So first of all, I would like to describe 6-star score. 16 or 18 symptoms are given specific score, and based on this score, if the person is having score which is more than 7, it is suggestive of dumping syndrome. If the person is having score which is less than 4, then there is possibility of other differential. So you can use these questionnaires in your clinical practice as well as for epidemiological studies. Before scoring the system, patient usually receive oral glucose, that is 75 gram of oral glucose. Primary focus of this scoring system is to identify early dumping syndrome. So it is very good to identify early dumping syndrome, but it may miss even some late dumping syndrome. Commonly used to define dumping syndrome since so many years, since the era of diagnosing of dumping syndrome, but this scoring system need to be yet validated in patient with bariatric surgery. So I think someone should do some study to validate this score in bariatric surgery. Another symptom score which has been described by Art et al. The Art et al. Score comprises of 8 symptoms of early dumping syndrome and around 7 symptoms of late dumping syndrome. And each symptom has given a score on a 4-point Likert scale. Based on this symptom score, you can easily discriminate between 2 categories. But even this score need yet validation in patient with bariatric surgery. So once you have patient with dumping syndrome, clinically you have diagnosed, but you want to confirm it. So when you want to confirm, you have to do certain provocating testing. And these provocating testings are a modified form of oral glucose tolerance test. What we do in OGTT, we give glucose and we measure blood sugar level before and after giving glucose. This is modified form of OGTT. Apart from measuring glucose, here we are measuring hematocrit, pulse rate and blood pressure. So it is very important. So there are 2 provocative testing. One is modified OGTT or a mixed meal test. Recently, Endocrine Society has given lot of weight to mixed meal test as compared to oral glucose tolerance test. What is a mixed meal test? Mixed meal test is a test in which we give mixed meal. Like this meal is 300 kilocalorie meal which contain equal amount of carbohydrate, fat and protein. And it has been given more weightage based on the study. First of all, let me describe what is modified OGTT. In modified OGTT, we give 75 gram oral glucose in the solution, 200 ml of water after overnight fasting. We measure blood sugar level, we measure hematocrit, we measure pulse rate and blood pressure before and at interval of 30 minutes up to 180 minutes. Similarly, when we give mixed meal, we measure baseline blood sugar level and these all parameters, and subsequently every 30 minutes we measure this parameter. Now how to interpret this test? So positive test means if the person is having hematocrit which is more than 3% from the baseline at 30 minutes, or if the person is having pulse rate which is more than 10 beats per minute after 30 minutes, these 2 tests or these 2 findings will tell that this patient is having early dumping syndrome. And second parameter is more sensitive than the first parameter. So according to various studies, this second parameter is more sensitive. Now development of late hypoglycemia, that means blood sugar level less than 55 milligram percentage at the end of 60 minutes to 180 minutes, that this patient might be having late dumping syndrome. So this is the very good test to differentiate, to diagnose, to confirm early as well as late dumping syndrome. There are various other tests available to diagnose dumping syndrome, like scintigraphy based study of gastric emptying. We can do scintigraphy based emptying of gastric emptying studies, but it has shown low sensitivity and specificity because of very rapid dumping of the nutrition into the lower intestine. Another important aspect is CGMS. Sometimes we do continuous glucose monitoring system. We use this CGMS device to diagnose late dumping syndrome. Sometimes patient may have unexplained symptoms at the end of taking food, at the end of 2 hours after taking food, and it might be responsive, maybe because of hypoglycemia. So we apply a device called CGMS. When you apply a device called CGMS, you can diagnose so many hypoglycemias followed by hypoglycemia preceded by hyperglycemia. So sometimes even CGMS device may help you to diagnose a complex case of late dumping syndrome. So it is very important. Now if you ask me treatment aspect, treatment include dietary modification, which is at most important in mainstay of treatment in patient with dumping syndrome. There are certain dietary supplements available to decrease the symptom of dumping syndrome, and we'll be describing that dietary supplement. If the patient is not responding to dietary intervention or dietary supplements, we have to use pharmacological agent like acarbose, somatostatin analogs like octreotide, lanreotide is now available, diazoxide, and very rarely people have used even nifedipine. And if the patient is refractory, we have to do surgical re-intervention. So let me describe one by one each. Dietary intervention is the mainstay of treatment in patient with dumping syndrome, and it plays a key role in the management of dumping syndrome. So what we advise to our patient, we advise to a patient that we need to take small frequent meal. Do not take large meal at a time. Do not take large meal at a time to dump the food into the lower intestine. Take a small frequent meal. It may be 6 to 7 meal in a day, I am not worried, but take a small and frequent meal. I also tell my patient to eat slowly and chew slowly. That means it also delays the absorption of the certain substance. Tell the patient to delay fluid intake until at least 30 minutes or an hour after solid limits. That is also very important, to delay the gastric emptying. Tell the patient to avoid refined carbohydrate, means simple sugars, in the diet. Consumption of fiber-rich fruit and vegetables should be encouraged. And even after this kind of dietary modification, if the patient is having persistent symptom, tell the patient to lie down for 30 minutes after meal. Immediately after meal, tell the patient to lie down for 30 minutes. And when the patient lie down immediately after meal, it also delays the gastric emptying and patient can have resolution of early dumping syndrome. So these are the dietary modification which we advise to our patient. We give this kind of advice to our dietitian to formulate the diet plan based on this principle. So it is extremely important. Dietary intervention is the mainstay of treatment in patient with dumping syndrome. Now there are certain dietary supplements available to treat dumping syndrome, like Gorgum. Gorgum powder is available commercially, even pectin is available commercially. When you add Gorgum or pectin, it increases the viscosity of the food, and by increasing the viscosity of the food, it delayed gastric emptying and decreased glucose absorptions. If you ask me regarding the dose of pectin and Gorgum, a 15 gram of Gorgum or pectin can be given before or with meal to delay the gastric emptying. Only limitation is that we have poor palatability and tolerability of the Gorgum, this kind of dietary supplements. And sometimes this kind of dietary supplement can lead to gas and bloating. So this is the common limitation of using this kind of dietary supplements. There are so many studies which is available. They are case series, not a randomized trial, because we have a quite small number of the patient, and even that case series says that this kind of dietary intervention with some form of dietary supplements does effective in patient with early as well as late dumping syndrome. Now, even after dietary intervention, if the patient is having persistent symptoms, you can use acarbose. What is acarbose? Acarbose is nothing but alpha glucosidase inhibitor. It slows the absorption of carbohydrate, or it slows the digestion of carbohydrate. Thus, by slowing the digestion of carbohydrate, it blunts the postprandial hyperglycemia. Once it blunts the postprandial hyperglycemia, subsequently decrease postprandial hypoglycemia. So it is a very important agent used in a patient with dumping syndrome. In India, we usually start with 25 milligram because our diet is rich in carbohydrate. If we start directly with 50 to 100 milligram, patient may have severe bloating and gas. So we start with 25 milligram and we gradually increase. It has to be given 3 times in a day with meal. What are the benefits? It improves glucose tolerance, it reduces GI hormone release, and various studies have shown that it reduces symptom of hypoglycemia because it slows the digestion of carbohydrate, decrease postprandial hyperglycemia and subsequent hypoglycemia. Major limitation is that acarbose is mainly effective in a patient with late dumping syndrome, but various other studies have shown that it has some benefit in patient with early dumping syndrome also. Bloating, a common side effect of acarbose. Flatulence seen in more than 10% of the patients who are taking acarbose. Sometimes it can lead to diarrhea also, which is seen in more than 1% of the patient. I had one patient of dumping syndrome. I started patient on dietary intervention along with acarbose, and he developed severe side effect of acarbose. There was resolution of the symptoms, but he was not able to tolerate acarbose. So that is quite common in our scenario. So what we should do next? So next pharmacological agent which is available is octreotide. What is octreotide? Octreotide is somatostatin receptor ligands or somatostatin analog. If you ask me about somatostatin is a pan-systemic inhibitor. That means it inhibits the hormone everywhere in the body. It inhibits the secretion of almost all the hormones in our body. One of the analog of somatostatin is octreotide. Octreotide is very effective option for the patient who fail to respond, or if the patient is having intolerance to dietary intervention or acarbose. It inhibits SSTR5 receptor more than SSTR2 receptor. And this SSTR5 receptor is very prevalent in GI tract. Because of inhibition of SSTR5 receptor, it delayed gastric emptying, it delayed transit through small intestine, it inhibits the release of almost all GI hormone, and it inhibits insulin as well as GLP-1 secretion also. So by inhibiting GI hormone, it is helpful in early as well as late dumping syndrome. It inhibits postprandial vasodilatation, definitely because of inhibiting release of certain GI hormone which has vasodilating property. So it is very effective modality. It treats early as well as late dumping syndrome. If you ask me regarding the formulation of octreotide, there are two formulations available. One is short-acting aqueous octreotide and second is long-acting LAR formulations. Both short-acting and long-acting formulation are effective, but some study says that short-acting formulation is better than long-acting formulation in terms of resolution of the symptoms. But whenever we are using short-acting formulation, we have to give 3 injections in a day. So that is little bit uncomfortable for the patient. Whenever we are using a large-acting formulation, we have to give once in a month preparation. So short-acting preparation, a dose may vary from 50 to 100 micrograms, 3 times in a day before meal, and long-acting formulation, we start with 10 milligram, and if required, we increase up to 20, 30, and sometime up to 40 also. But usually starting dose is 10 milligram, and once in a month injection is sufficient. Overlapping of both is also recommended, that initially patient should be on short-acting formulations and long-acting formulation simultaneously. Once the effect of long-acting formulation comes into the role, you can switch off short-acting formulations. Side effect, we all know that 10% of the patient can have nausea, even diarrhea and steatoria with octreotide. Gallstone formation is a common side effect of octreotide which can be seen in around 11 to 34% of the patients. So if the patient is taking octreotide, monitoring in terms of GB stone or periodic USG is recommended. Pain at the site of injection can occur in 10% of the patient. And there are so many studies which supports the role of octreotide in patient with early as well as late dumping syndrome. So it is very effective modality of treating the patient. Another medical management is diazoxide. We know diazoxide is a potassium channel opener, and it opens the potassium channel and subsequently decrease insulin secretion. It is available as a brand name of Udemine. A single tablet will cost 54 rupees, and the whole bottle which contains 100 tablets will cost 5,400 rupees. Regarding the use of diazoxide in patient with dumping syndrome, we have anecdotal evidence. It is off-label use. Dose which you can use is 100 to 150 milligram 3 times in a day. Diazoxide being a potassium channel opener, it decreases insulin secretion. So it is helpful in patient with late dumping syndrome rather than in patient with early dumping syndrome. So diazoxide can be effective modality in patient with late dumping syndrome. Surgical reintervention, you know better than me. It should be considered in patient with refractory postprandial hypoglycemia. Sometimes you have to do gastric pouch reconstructions. Pancreatic resection if the patient is having intractable recurrent hypoglycemia in spite of using all the modality. Maybe partial and distal. But let me tell you, when you do partial and distal, effective only in 40 to 50% of the patient. Sometimes a combination of both has also been done in various studies. So if I summarize, if you have a patient with dumping syndrome, confirm it by doing a glucose challenge test. If glucose challenge test is negative, explore other differentials. If it is positive, advise lifestyle modification, which is utmost important. You can use acarbose along with lifestyle modification. If the patient is still symptomatic, use octreotide. And in spite of that, certain patients are very resistant to even octreotide. In that situation, you have to consider surgical re-exploration or re-intervention. So dumping syndrome is well known, but under-recognized, under-diagnosed conditions. A diagnosis is based on the clinical suspicious and modified oral glucose tolerance test or a mixed meal test. Initial therapy is focus on dietary measure for 3 to 4 weeks with or without acarbose. And if the patient is not responding to acarbose, you have to use octreotide. Thank you. If you have any question, please ask me. Yeah, please.
A very nice person. I think surgeons has never read about dumping so much. I think your lecture is
Thank you,
mind
sir.
opening. I think
Thank you, thank you,
we
sir.
learned a lot. And few things about, we have come across many persons who are getting recurrent hypoglycemias after gastric bypass, which may
Yes,
not be
yes.
dumping syndrome, and we treat them differently. Only the role of beta blocker in such situation when they have consumed symptoms like tachycardia, flushing and all. So with acarbose we add even beta blocker,
Yeah.
they do very well. That is
Yeah.
one. And second, acarbose is, I think I prescribe more than even any endocrinologist because almost every person they get acarbose because
Yeah.
that reduces your sweet craving. Because after gastric bypass, to sleep gastric, a lot of people they start eating sweet
Yeah.
and because
That's
of
possible.
that increased insulin response. And if we start with acarbose, we can avoid that sweet.
Definitely. It's a really very good agent. Even in my diabetic practice, I use a lot of carbose. It is better than voclibose. I can say 100% it is better than
Hardly any side. I have
voclibose.
not seen any patient who has even single side.
We have seen a lot of patients, and what is your opinion about calcium channel blockers?
Yeah.
Because they are also potassium channel openers.
Yeah, definitely. As I have described earlier in my presentation, that some people do use calcium channel blocker like, sorry, I just. As I have mentioned, some people do use calcium channel blocker, but their evidence are small. The efficacy in terms of reduction in the symptoms is not as high as like a carbose. Okay. Sometimes you can club this agent. I have
Actually,
seen one of these studies.
in reactive hypoglycemia, which are not diagnosed dumping,
Yeah.
but it is a reactive hypoglycemia where after food there is hypoglycemia,
Yes.
but no tachycardia, no sweating.
Sorry.
Then once you have documented that it is not dumping but reactive hypoglycemia, which is again worrisome. The patient's
Yeah.
sugar goes down. In those patients, nifedipine works wonderful.
Yeah, definitely. Even we see a lot of patients who are having reactive hypoglycemia without any bariatric surgery. They are just so normal with a history of diabetes mellitus in the parents, having a lot of insulin resistance. And we do this kind of test and we identify reactive hypoglycemia. We try with the carbose, and many people have tried even calcium channel blocker and it works sometimes. But it works robustly. To say that, we need a larger study. Okay. Just based on a case report or one finding, we cannot say that it is acting robustly. So that is my take on. Yeah.
We have seniors like Dr. Navaria and you. So how many times you would consider doing something surgically to address this problem? Number one. Number two, please tell us that when are you worried? Whether dumping syndrome, the symptoms are common when they describe and they give mostly dietary modifications. But when you get worried that you might have to choose, and what period in time after surgery?
You brought this continuous glucose monitoring, which is very, very important. Any person who get recurrent hypoglycemias or dumping, CGMS is very, very good mod, which we use routinely because we need to find out what stage they are getting hypoglycemias. We can always target and we can modify that lifestyle by doing this. So far I have done only one reversal of gastric bypass because of recurrent hypoglycemia that was again done outside in Chennai, and patient was getting admitted because of hypoglycemia and the life was miserable, and he came back to us, came to me and I reverted back to normal. So far he has not gained weight. I am following that person for almost 3 years now and his hypoglycemia has completely recovered. There is no more hypoglycemia. So don't even think about pancreatectomy or partial pancreatectomy. What is described, maybe few case reports, but we don't have to do this. Before that, I think reversal is a better posture than pancreatectomy because that is more morbid posture. We should not try that, but we can always reverse these patients.
Yeah.
Actually,
That is
there was
true.
a paper by Cummins. Actually, it was a very nice paper. If, for your knowledge also, if there is a hypoglycemia persistent where you think surgery is needed, and you are in a dilemma, want to do or not, because reversal again patient may gain weight. Pancreatectomy is a very, very morbid surgery to
Definitely,
do.
it's a really morbid
So
surgery.
what he used to do is put a gastrostomy tube in the distal stomach, and he saw the hypoglycemia goes. This
Yes.
type of patients you reverse and they are out.
Yeah, that is true, which I have described in last line, that continuous enteral feeding. by gastric tube placement or GJ feeding tube, sometimes you can revert or you can avoid this surgical reintervention or even pancreatic resection. It's yes, definitely true. So sometimes continuous enteral feeding may be the options.
Enteral means you keep eating very frequently. That can reduce, but small
Yeah.
quantity. Before
Small
you feel hungry, they keep eating. So that
Yeah.
will also avoid
Pancreatectomy is a very last resort. Been described in various studies. After doing a surgical reversal, some patient may have limiting hypoglycemia. Only in that situation, this pancreatic resection is advisable. But let me tell you, even after doing a partial pancreatectomy, the success rate is not high. Around 40% of the patient get relief of the symptoms, and recurrence is quite common. So it is not a surgery of choice most of the time.
I think that is when we document acidoblastosis.
Yeah.
By scintigraphy, we can find this areas of hypersecretion of insulin,
Yeah.
maybe more beta cells.
Yeah,
Those
yeah.
are the only patient after documenting and
Nesidioblastosis. So it's a, as sir has rightly said, nesidioblastosis is the only situation where we do, after doing almost all the thing, we give patient 72-hour fasting. If the patient is having nesidioblastosis, they will develop hypoglycemia by 72-hour fasting. And we document that this patient is having nesidioblastosis by doing a specialized scan called DOPA-PET or Exendin 4-PET CT scan. Not a routine FDG or DOTA-TAT PET scan. And once you have documented that this patient is having nesidioblastosis, then in that situation you can offer. Sometimes we go up to the extent of hepatic venous sampling. We did hepatic venous sampling in one of our patients.
portal venous septum.
Portal or hepatic venous sampling. We give calcium and we take a sample from various arteries simultaneously, and we document hypersecretion of insulin. Quite a common we do when we don't identify insulinoma, where patient is having a focal lesion. Thank you. Thanks a lot.
That was a fantastic lecture. Thank you very much, Dr. Dalwadi. And now we'll have a video.